So this is time to start our plenary 3. I would like to call upon our consultant physician, Dr. P. Mayurudan sir, to chair this event. This is a guest lecture by Dr. Jimmy Chong, consultant physician, diabetes and endocrinology, Hampshire Hospitals, NHS Foundation Trust, Winchester, UK.
I am proud and honored to introduce the guest speaker, Dr. Jimmy Chong. Dr. Jimmy Chong is a consultant physician in diabetes and endocrinology and currently attached to the Royal Hampshire County Hospital of Hampshire Hospital Foundation Trust, Winchester, United Kingdom. He graduated from Trinity College, Dublin, with honors in social medicine and surgery in 1992. And he received CCST Award in July 2000 with dual accreditation of consultant in general internal medicine and diabetes and endocrinology. He has the qualifications of BA, MB, BCH, BAO, MD, MRCPI, and FRCP London. In addition, currently he is an Associate Medical Director for Governance, Director of Medical Education for St. George University, Grenada, UK Associate Chair for Medicine, MRCP PACES Examiner for RCP London, International MRCP PACES Examiner for RCP London, Chair of Examiners for MRCP PACES RCP London. Dr. Chong was holding the administrative posts of Clinical Director for Medicine, Royal College Tutor, Wessex Specialist Training Committee Chair for General Internal Medicine, Regional Specialty Advisor for General Internal Medicine, member of the Question Writing Group for MRCP Specialty Certificate Examination, Chair of the Combined Local Foot Network for North Hampshire and West Hampshire, and Clinical Governance Lead for the Division of Medicine. Dr. Chong has published more than 60 publications, including research papers, review articles, and case reports in his specialty of diabetes and endocrinology and general internal medicine. I am proud to say that Dr. Chong was my supervisor during my post-MD overseas training for 2 years in diabetes and endocrinology at Royal Hampshire County Hospital in United Kingdom. Without further delay, I warmly welcome Dr. Chong to deliver his speech on a very interesting topic of adrenal incidentalomas. Over to you, Dr. Chong.
Thank you, Mayu. I'll just share my slides. So thank you, first of all, to the BMA for this kind invitation to present. I'm really honored to do this presentation to you this morning in the UK. This is a picture of Dr. Mayurudan when he passed his MRCP exam. I must say, as an examiner and chair of examiners for the PACES exam, it is not easy for international graduates for whom English is not the first language to pass the PACES at the first attempt. But Mayu managed to do that. So I know he's giving a talk or a session later on the MRCP examination. So I'm sure he'll be able to give people very good advice how he achieved it. In addition to being an excellent doctor, Mayu was also a very popular member of our team. These are pictures from our Christmas party in December 2019. Of course, at the time, we didn't realize that the whole world was going to change and we recovered. In case you're wondering where I live, I'll just show you a few pictures of Winchester, which is in the south of England. It's a small city. It is a historic city, and it's meant to be one of the most expensive cities to live in the UK, unfortunately, because a lot of people live in the city and then they travel to London by train to work and come back to live in Winchester, so it raises the price of properties. But it is quite famous for the cathedral and it used to be the ancient capital of England. This is King Alfred, the Anglo-Saxon king. That was back in the 9th century, quite a long time ago. This is a picture of the hospital I work in, and where this arrow is exactly where I'm giving the talk now. My office is actually based there, but the walls are quite modern in the hospital. A lot of the information I'm going to give you is based on 2 authoritative review articles on adrenal incidentalomas. Our practice is guided a lot by this European Society for Endocrinology guidance, published in 2016. And more recently, there's another really good authoritative review on adrenal incidentaloma, published in Endocrine Reviews Journal in December last year. By definition, the adrenal incidentaloma is an asymptomatic mass detected on imaging not performed for suspected adrenal disease. And it is actually quite common because up to 2% of the population has this adrenal incidentaloma. So it is very common. And the age is also significant because the older you are, the more likely you're going to have the incidentaloma. It's quoted to be more than 7% above the age of 70. The other review article quoted 10% for people above the age of 70. If the patient is below 40 years, the adrenal nodules are much less prevalent. And it is quite rare in young adults and children. And therefore, we have to investigate the younger patients quickly for any possible underlying cancer. The adrenal incidentalomas could be cancerous in 2% of the patients, and about 10% can produce adrenal hormones. So we tend to investigate for both adrenal cancer and adrenal hormones in parallel. This is a table taken from the European Journal of Endocrinology, and it shows the type of tumors that can be present once we find an adrenal incidentaloma. As you can see, the vast majority, 3/4, are non-functioning tumors, and they're benign. And then we can have tumors secreting cortisol, leading to Cushing's, tumors secreting aldosterone, leading to primary hyperaldosteronism, tumors secreting adrenaline, or metanephrines, giving you pheochromocytoma. More importantly, some of those incidentalomas could be cancerous, or they could represent metastases from another primary source of cancer. And those lumps could also be due to cysts, to myelolipomas, or ganglioneuromas. It is generally agreed that we do not investigate the lump unless it is more than 1 centimeter in size. So if we have a CT scan saying there's a 0.8 centimeter adrenal mass, we do not tend to investigate those lumps because very often they don't grow in size anyway. But when we investigate, as I've mentioned, we investigate for potential malignancy and hormone excess. And the way we do that, we do non-contrast CT initially. And on the CT, we would usually ask the radiologist to give us the so-called Hounsfield's unit. This measures the amount of X-ray absorbed by the mass as compared to water. And we use a figure of 10 as a cutoff. So if the Hounsfield's unit is less than 10, it's considered to be benign. And if the lump is less than 4 centimeter also, in addition to the HU of less than 10, we do not recommend any further imaging. But if the mass is more than 10 Hounsfield's unit, we recommend further imaging, either by an MRI or rescanning with a non-contrast CT 6 to 12 months later on. The other thing is that size matters. I've mentioned that a lump which is less than 1 centimeter is not investigated. But if it is more than 4 centimeters, there's a high risk of malignancy. There's a large Italian cohort study that reported that 4 centimeter cutoff had a high sensitivity of 93% for prediction of malignancy. And therefore, if the mass is more than 4 centimeter, but less than 10 HU, we would still keep the patient in the review and reassess them with further scan in 6 to 12 months. And if the lump increases in size significantly, by that we mean at least 20% increase in size, in volume, with 5 millimeter increase in diameter, that would be considered significant and we would recommend surgery. Now, I was involved in a medical legal case. I was asked to give an opinion by the patient solicitor who went to another hospital back in 2011. He was age 59. Another time he presented in a hospital, another hospital in the UK, to the emergency department with a 4-hour history of passing bright red blood and clots on opening his bowels. So he had parectal bleeding. He was reviewed by the surgeon, had blood transfusion, and he underwent investigations. The CT scan, to look usually for signs of malignancy, the report said there was no definite blood mass identified, no convincing mass. There was an unusual appearance of a distal sigmoid, which may relate to bleeding, but he could not confirm this. There were signs of diverticular disease, but he was suspicious of the distal sigmoid. So the patient had a colonoscopy which showed diverticular disease in the sigmoid colon and also in the descending colon and the cecum. An OGD showed an area of angioectasia in the first part of the duodenum that was bleeding. So the endoscopies, OGD and colonoscopy, did not show any malignancy. He also had a capsule endoscopy as an outpatient, which was normal. He represented to that hospital about 3 years later, in January 2015, with a history of hematuria over 10 days and painless maturation. A flexible cystoscopy was normal, and he had a CT scan of the urinary tract, which showed a 3.9 centimeter mass, adrenal mass. The Hansfield's unit was 35, and I've mentioned earlier on, if it's more than 10, it could potentially represent malignancy. So he was also found to have some ureteric calculi and was referred to the local endocrinologist for further investigations. On further review, though, it was discovered that his CT scan that was done for the PR bleeding in November 2011 had an adrenal mass that was missed. It wasn't big, but it was 11 millimeter in size, and that had increased in size to 3.9 centimeter, about slightly more than 3 years later. So the team at the time felt this was a significant increase. His hormones from the adrenal glands were negative, and he was sent for surgery. It turned out to be adrenal carcinoma, and the margins were positive, which means not all of the cancer was resected and it was spreading outside that area. So he was sent for adjuvant radiotherapy. Unfortunately, he died in 2017 from the metastatic adrenal cancer. By the time I got involved in 2017, the patient was alive, and he had instructed his solicitors to seek compensation because of the missed adrenal mass. Now, it turned out that there was differing radiological opinions regarding the size of the adrenal mass, because the radiologist, one radiologist said it was 11 millimeter, and another radiologist that was employed by the hospital, defending the hospital, said it was 9 millimeter. Now, this is significant because, as I mentioned, if it's more than 10 millimeter, it is agreed generally to investigate the patients, i.e. the patient would have had repeat CT scan later on. But in the end, the case was settled out of court, financial compensation, although the patient had sadly passed away. So that's a medical legal case. And unfortunately, in the UK, in the Western world now, this is quite common. There's more and more medical legal litigation instances. So for patients who are found to have an incidental adrenal mass, we tend to investigate in parallel for malignancy or for any excess hormone secretion. So for malignancy, as I said, if it's below 4 centimeter, if the HU is less than 10, it's benign. We do not recommend following up those patients. But if the size is more than 4 centimeter, HU more than 10, then we would follow those patients up. In some instances, like in the patient with medical legal example, we go straight for surgery. Now, the conditions we tend to screen for hormone excess would be pheochromocytoma, Cushing's, and primary hyperaldosteronism. You will all know that the classical symptoms of someone with fear would be high blood pressure, headache, and sweating. And these tend to be episodic, which means sometimes the patient feels quite well. And when the adrenal tumor secretes the hormones, they feel unwell, maybe for 15 to 30 minutes. Other symptoms would include flushing, maybe feeling anxious, having palpitations, tachycardia, abdominal pain. We did have a patient who came to hospital with abdominal pain about five years ago, was found to be constipated, had intestinal obstruction. She went for surgery because of the obstruction, and unfortunately there was an adrenal mass, and the surgeon did not realize that it was actually pheochromocytoma. The patient had a fear crisis post-op, but he can present with abdominal pain or even intestinal obstruction. So other symptoms would be dizziness, heart failure, and because the adrenaline induced insulin resistance, it could make diabetes worse and give them osmotic symptoms. The way we investigate those patients would be for 24-hour urine collections with metanephrines. As I've mentioned, the tumors could be episodic in relation to secreting the hormones, so sometimes we do more than 24-hour urine, more than one collection, 2 to 3. We can also do blood samples for metanephrines. The sensitivity and specificity is about the same for both urine and plasma metanephrines. The patients are usually advised to avoid caffeine or sympathomimetic drugs before urine collection. And if they have a blood test, the patient is advised to lie down for 30 minutes at least before the measurement for plasma metanephrines is carried out. When I was studying medicine in the late 80s, we were measuring VMA in the urine to diagnose pheochromocytoma. And then when I was practicing in the late 90s, we were measuring urine catecholamines, noradrenaline and adrenaline. But then more recently, we've been measuring the metanephrines, which are the normetanephrines and metanephrines. So these are all kind of metabolites of noradrenaline pathway and adrenaline pathway. I'll give you an example of a patient who had an adrenal incidentaloma and a fear. So this lady is 50 years old. She presented last year with hematuria, had a history of asthma, but not much else really in the history. She was seen by the GP initially, checked the urine. There was no definite hematuria, but the GP referred her to the urologist, who organized for ultrasound scan of the kidneys and a cystoscopy, which was normal. The ultrasound showed a mass in the upper pole of the left kidney. And she had a CT which showed this mass there, a 4.3 centimeter mass. So the size of the mass is more than 4 centimeters. And she had investigations, and that's the axial view of the CT scan showing the 4.3 centimeter mass. So from the history, she was quite well. She had no palpitations, sweating, or headache, any symptoms to suggest a pheochromocytoma. She was able to exercise every day. She was wearing Fitbit that monitored her heart rate constantly. And she said that her resting heart rate was okay. It was 65 to 68 beats per minute. And the blood pressure was usually okay. There was nothing really to suggest a pheochromocytoma, but her urine investigation should raise normetanephrine and raise metadrenaline, noradrenaline, metadrenaline. As you can see, it goes up to 5-6 times upper limit of normal. And on repeat again, it was very high. So it was consistent with a pheochromocytoma. She had an MIBG scan, which is usually quite specific for pheochromocytoma. This is a scan I picked up from the web. It is not for this patient, but it shows an increasing uptake of the MIBG in the left adrenal gland. So before surgery, we tend to give the patient alpha blockade. In the old days, we would use phenoxybenzamine, but now doxazosin is good enough. We give the patient a small dose only because her blood pressure wasn't high, and that's all she could tolerate. There was no need to give a beta blocker because she wasn't tachycardic. She had a successful surgery in April this year, and her latest urine for the metanephrines were normal. The other condition we screen for would be Cushing's. This is a lady who was 52 that I saw about 4 or 5 years ago now. She initially went to a GP with vague abdominal pain, had a history of type 2 diabetes and hypertension, and the ultrasound was booked by the GP for potential gallstones in view of the abdominal pain and being overweight, but was found to have a 5.5 centimeter mass above the left kidney. And that's a picture showing the 5.5 centimeter mass above the kidney. When I saw her in the clinic, she mentioned that she had gained a significant amount of weight, up to 25 kilos over 6 months. She mentioned that her diabetes had worsened and her blood pressure was higher over the time. But her skin was thin, she had some weakness of the legs, was sweaty, was flushed, and had tingling. That's a picture of her at the time. You can see there was nothing typical of someone with Cushing's because she's a lady with overweight that we will see a lot of people in the UK these days. There was no definite plethora. There was no definite abdominal striae. In some people with Cushing's, you can get a dorsal fat pad. You could see a little bit there, but a lot of people who are overweight will have that picture. So nothing definite, but in my mind, I was still thinking we should screen her for Cushing's because she had said that her diabetes had worsened and her blood pressure was high. But before I mentioned this to her, she said to me, "Doctor, could I have Cushing's?" Now, Dr. Myradan will tell you that in the UK these days, people would usually look up the internet and research their symptoms for potential diagnosis. And she's one of them, actually. She was spot on because she did have Cushing's. The way we investigated her was to do an overnight dexamethasone suppression test, where we asked the patient to take 1 milligram of dexamethasone at midnight, and the next day we measured the cortisol. So the baseline cortisol was high, and it did not suppress at all. It should be less than 50 the next morning to exclude Cushing's. The other test we do is the ACTH, which comes from the pituitary gland. If the ACTH is suppressed, it means the high cortisol comes from the adrenal gland, giving a negative feedback on the pituitary gland. So she did have adrenal Cushing's. Her urine metanephrines and aldosterone levels were normal. So she had a CT scan following the ultrasound, which actually showed quite a large adrenal tumor measuring 7 by 5 by 6 centimeters in size. She had surgery, and it turned out to be adrenal cancer, actually, secreting cortisol. This is quite rare because at primary adrenal carcinoma, the prevalence is only 1 to 2 per million per year. Most of them are, some of them can be functional, 40 to 60%, but mostly associated with Cushing's. These are more typical pictures of someone with Cushing's. I had this patient with pituitary Cushing's many years ago. As you can see, she had this round face and pink striae on the abdomen. She had signs of supraclavicular filling and signs of epiphysis nigricans, which can be a feature of insulin resistance. She had pink striae also on the on the arms. The other area we tend to look for pinch striae will be in the axilla. And some of those patients can get thinning of the skin, leading to bruises on areas of the body. So she has some bruising on the legs. This is her after her surgery for Cushing's. She looked quite different post-surgery. Just to remind you briefly, Cushing's could be due to the adrenal lumps that I've mentioned, which could be adenomas or carcinomas. But the majority of Cushing's would be iatrogenic, actually, from the prednisolone or steroids we give patients to treat the asthma and COPD, etc. Pituitary Cushing's will be more common than adrenal adenoma or carcinoma. And then you can have ectopic ACTH from a lung cancer, for instance, leading to Cushing's. I've mentioned already that the patient we had an overnight 1 milligram dexamethasone suppression test. The cortisol the next morning should be below 50 nanomole per liter to exclude Cushing. We've got to remember that patients who are taking the combined oral contraceptive pill, so if they have estrogen, that needs to be stopped for 6 weeks at least before measuring cortisol, because estrogen raises the cortisol binding globulin, so the cortisol you measure in the blood is the total cortisol. It will be high with someone with the OCP. So what happens if the patient fails the 1 milligram dexamethasone suppression test? Well, we can do the low dose dex, which is 0.5 milligrams of dex 4 times a day for 48 hours to confirm Cushing's. Both the 1 milligram dexamethasone suppression test and the low dose, they're both used to confirm Cushing's. But we check the basal ACTH. And if the ACTH is raised, it would usually mean it coming from the pituitary gland or an ectopic source. And to differentiate between those two, we can do the high dose dex, where you give 2 milligrams of dex for 4 QDS 4 times a day for 2 days. In patients with pituitary Cushing's, most of them were suppressed, but none of the patients with ectopic ACTH were suppressed. The other thing we can do is infer pituitary sampling, which we actually do in a neighboring hospital in Southampton, where samples of ACTH is collected from the pituitary veins or the pituitary or sinuses, and we measure the gradient with the ACTH in the blood. The third clinical condition we will investigate will be primary hyperaldosteronism. Now, in the medical textbook, it will usually say someone with primary hyperaldosteronism typically has got high blood pressure and low potassium. But you can have someone with normal potassium. In fact, up to 5.5% of patients with adrenal incidentalomas who have got primary hyperaldosteronism will have normal potassium. And some people will have normal blood pressure, so it can happen in both. But both endocrine guidelines I've mentioned initially, the European and the American one, say if your patient has got a normal blood pressure and a normal potassium, you do not need to investigate for primary hyperaldosteronism if they have the adrenal incidentalomas. And the way we check that will be to measure the aldosterone-renin ratio. Ideally, someone's been out of bed for at least 2 hours, so they come to hospital, that's fine. They need to sit for 5 to 10 minutes. They need to have plenty of salt intake before the test, and ideally replace the potassium to make the test more accurate. If some of them are already on some medications, specifically the aldosterone receptor antagonists, such as spironolactone, they need to be off this for at least 4 weeks. If they are on other medications which interfere with aldosterone-renin, such as ACE inhibitors, beta blockers, diuretics, we can still interpret the levels of the aldosterone-renin ratio. But we definitely need to stop spironolactone or eplerenone, which is the other aldosterone receptor antagonist, for at least 4 weeks before we measure their bloods. Now, as I was struggling actually to think of a patient to present to illustrate someone with primary hyperaldosteronism, but I saw Jesus 2 days ago. Actually, it was a lady called Mrs. Jesus, her surname, from Venezuela. She's 74, presented this year with abdominal pain and constipation. She was admitted under the surgeons. She had a history of abdominal hernia, for which I had surgery in Venezuela many years ago. She had a CT scan of the abdomen, which did not show any obstruction of the hernia, and was found to have this incidentaloma, measuring 31 by 17 millimeter in size. She has a history of hypertension, takes amlodipine, the calcium antagonist, but blood pressure tends to be quite good. In the clinic, it was 130/80, and she measures it at home also, and it's usually quite well controlled. Her potassium was normal, and looking through her records on the computer, they've been normal for a few years, so there's no signs of hyperkalemia. Her name, as I mentioned, is Jesus, and this is her aldosterone ratio. It was raised at 115. If you can see here in the comment, it says if the ratio is more than 91, it is consistent with an autonomous production of aldosterone from the adrenal gland, followed by advance, etc. But the problem is the renin itself, you can see, is within normal range. So I think myself, this is not primary hyperaldosteronism. What I'm going to do is to first of all repeat it. And if it is still raised, the other test I can do is a saline suppression test to check for it. But I'll be quite surprised because in most of those patients, the renin is suppressed or low. You won't be within that level, at that level at 4.4. So what I've done is to check for Cushing's, although she wasn't clinically Cushingite, and I've booked her for another CT, this time asking for dedicated views of the adrenal gland, asking for the XU, the Hounsfield's unit, and to look for any significant increase in size. So I'll see her maybe in a month or two after those results and see how she gets on. So I've already talked about the investigation to look for malignancy, and to summarize, investigations to look for hormone excess, for Cushing's, pheochromocytoma, and for primary hyperaldosteronism. I've mentioned to you this medical legal case from that hospital where the patient turned out to have an adrenal cancer and unfortunately died, but I do chair the serious incident panel in the hospital, and we do have cases, not infrequently, in radiology where masses are missed by radiologists, nodules on chest x-rays or even nodules on CTs, because the CT scans done for other conditions, someone with, like our patient with GI bleed or someone with abdominal pain, very often they can miss masses in the adrenal gland or the area. So I think the future will be for artificial intelligence. So missing those diagnoses could be due to high workload, and there's a high cost of litigation. So I think the future is for artificial intelligence. There are software available which can pick up abnormal findings on the CTs or X-rays, and these will help assist radiologists. Obviously, they will not ever replace radiologists, but they will help assist radiologists. In that article from the Lancet, there's a mention of artificial intelligence picking up adrenal incidentalomas and even differentiating whether they could be malignant or benign. This is a picture of me in Sri Lanka a few years ago. That's Ravi Loki Gamagi. He's a consultant now in Galle, near Colombo. He was actually my first trainee from Sri Lanka through the MTI program through the Royal College. He's a consultant doing really well, but that's one of my favorite trips. Actually, I managed to see the elephants in Sri Lanka. That's Jenny Webb, our previous education center manager. Thank you.
Thank you, Dr. Chong, for a very interesting case-based presentation on adrenal
I'm happy to take any
incidentalomas.
questions, if any.
Dr. Chong, would you like to say a few words about midnight salivary cortisol test?
Yeah, so this is another option we can use. It was used as a pilot in Southampton Hospital, but it hasn't really taken off at the moment in common practice. So we tend to do the overnight dexamethasone suppression test. The other one we can use is actually to do the midnight serum cortisol, and if the midnight serum cortisol is below 50, that would usually rule out Cushing's. As you know, there's a diurnal variation in the cortisol, which is low at midnight and goes up in the morning. So to answer your question, yeah, salivary cortisol is used in some centers, but not in our hospital.
Okay, thank you very much. I think there is no much questions. Thank you very much for spending your time with us and sharing the photos. Thank you very much.
Thank you. You're welcome. Bye-bye.
Thank you, Dr. Jimmy Chang, for throwing that insight on a very rare disease.